I want to talk about large-scale screening for social determinants in pediatric settings. So 3 objectives for today is just to describe all the current forces that are leading to promotion of large-scale social determinants of health screening, and then giving an overall perspective of the considerations if you're going to screen for social determinants of health, and then talk about very specific challenges related to large-scale screening as opposed to what we've done historically. So this is a study I love to give as an example because it shows why health equity and social determinants of health is a very layered field. And so the purpose of this study were twofold. It was overall to understand disparities in the use of hospitals for major surgery. So first, they want to look at the racial differences in the proportion of patients having surgery in what they deemed low-quality hospitals versus high-quality hospitals. And then the second objective was to determine whether geographic proximity had anything to do with where people went and explain some of these differences. So very simple study. They used Medicare data files, so essentially everyone had coverage. Now that comes with a big asterisk because not all healthcare coverage is the same, but in general, they had some coverage. So these were individuals 65 years older who were undergoing the procedures you see below. They had a measure for hospital quality, which was based on morbidity and mortality, and they had a measure for geographic proximity, basically how close you lived to these hospitals, and they did a logistic regression. So what was interesting about this, so, and very simple, Black versus white. So Blacks were more likely to have surgery at what were deemed low quality hospitals, again, based on morbidity and mortality. They were less likely to have surgery at high quality hospitals, but they actually lived closer to high quality hospitals. So when I saw this study, I was totally blown away in the sense of how can you explain these results? And so these are the sort of the things that I came away with, the insights I came away with looking for this study, is that it's a number of factors. One, it could be the referral patterns of their primary care providers. So they may send these patients to particular hospitals or subspecialists that tend to be at these what we deem low quality hospitals. The second thing is for patients, the metrics around what makes quality is not always known. If there are health literacy issues, other types of factors as well. They may not know, this is what morbidity is, this is what mortality is. These are, length of stay measures I should be looking at. And then there are all these factors about patient experience as well and how welcoming our institutions are. So it's possible that some of these Black patients had bad experiences, what were deemed these high quality hospitals. And it could have been for them, it could have been for their social network, it could have been for family members. And alternatively, they may have actually had great experiences of what were deemed these low quality hospitals. And it may be because what are these low quality hospitals, at least by our metrics, again, I say our, it could be that they have the services these individuals need. So it could be interpreter services, it could be social work support, it could be food pantries. So all of that actually elevates these places to be high quality for these particular individuals. So I think one of the key points too is that patient experience drives value in addition to the things that we in healthcare typically think about. And overall, my sense was this is where the social determinants of health come together, right? Because high quality hospital, low quality hospital, based on whose definition, all these other factors really come into play in terms of where people go to get their healthcare. So social determinants of health, I think we all have a pretty good definition. It's all these life enhancing resources, food supply, housing, the built environment, education. And it's not just that, it's how they're distributed in society as well. So there's a great rationale for addressing social determinants of health. So I think there have been studies since the 70s that show that healthcare, in terms of what we do on a daily basis, only accounts for 10 to 20% of health outcomes. So life expectancy, quality of life, for example. And then alternatively, we have evidence that shows a strong link between social determinants of health and health outcomes. And when you look globally in terms of how the United States compares to other countries, we invest so much more in healthcare relative to social care. And then when you look at our health outcomes, we do much more poorly related to other countries who spend more of their resources on social services. So it's just an interesting perspective when you look at us in the global landscape and where we should be making our investments. So this has been the theoretical rationale for really going after social determinants of health. But what I want to talk to you about today is there have been all these new forces just in the last couple of years really pushing us to think about social determinants of health in a different way. So let's start off with payers. So payers have been making the push. The Centers for Medicare and Medicaid, so CMS, years ago started something called the Accountable Health Communities Model, which is essentially focused on very active social determinants of health screening people referring them to community organizations, patient navigation, wraparound services, and funding different organizations that were doing this type of work. And then in 2016, there were all these changes in the Medicaid managed care regulations. So some of it was promoting alternative payment models. So not just fee for service, but promoting more value-based models where you can look at things like health equity and social determinants of health and reincorporate that into reimbursement. The other thing that was promoted with those changes is in lieu of services and value-added services. So in lieu of services just means substitutes. So you can say, for example, instead of having a mom do her prenatal visit at the hospital or at the ambulatory clinic, that someone comes to her home to do that. So that meets that person where they are in terms of their access to care. So that's in a lieu of service. And then there are also value-added services where things that just benefit patients above and beyond what is in the Medicaid contract. And so that, for example, could be that you discharge a patient and maybe if you have an innovative program, they get food assistance for 6 weeks to help them after their discharge, because then they don't have all these competing factors of how do I care of my chronic condition, my discharge, plus actually eat. And so that would be a value-added service. The last thing that's really come about, has anyone heard of Z codes? So Z codes are these, in theory, billing codes that can have social determinants of health connected to them. So the idea with Z codes is if you can, in theory, account for what you've done as a provider with regard to social determinants of health, you can actually get reimbursed for it. And so the idea is this is a way we incentivize providers to actually to start addressing social determinants of health. It also gives us a mechanism to do some population health management, right? Because if you're in your managed care organization and you have all these Z codes being used, then you can see where the issues are with your plan members and actually make some interventions. So I think where we are with Z codes, people aren't using them in the way that we should. And I think a lot of us still don't understand what they are, but theoretically they're out there as a way to further incentivize social determinants of health screening. So those are payers. Another further step just this year, that now there are going to be increased payments for measuring 3 health equity measures. So one of them is just going to be, and this relates to hospitals specifically, one is going to be what kind of culture are you setting in terms of addressing health equity, but then 2 of them are specifically going to focus on health-related social needs, screening as well as providing support. So you can see from a number of different areas, payers are now at a national level really pushing social determinants of health. So let's go to our next stakeholder, the Joint Commission, which everyone loves, obviously, when they visit. So the Joint Commission in this past year in June released a report essentially saying, now we're going to focus on health equity as well, and it's going to become a standard. And so here's what they have here. I think it's about 5 or 6 things focused around health equity. So having leadership, looking at data, looking at differences in outcomes, but the ones specifically related to social determinants of health I've highlighted here. So assessing patients' health-related social needs and providing information about community resources and support services. So they're very explicit. This is now a requirement from Joint Commission. And here you can see a little bit more specifically about the areas. They just give as examples of these are the types of areas that you can cover. So access to transportation, difficulty paying for prescriptions or medical bills, education and literacy, food insecurity, and housing insecurity. They don't give a lot about exactly how to do it, but these are the areas in theory you can focus on. So we have payers, we have Joint Commission, and the other lovely one that's come out in the last couple of years is hospital rankings. And so just about 2 to 3 years ago, US News and World Report had added a health equity section. And so this health equity section has a number of things, but I'll focus on the ones that are related to social determinants of health. The first one is patient data collection. So demographics, race, ethnicity, language, gender identity, sexual orientation, both for the parent and for the child as well. And then ask questions about all these other things you should be screening for: employment, housing insecurity, food insecurity. And then it actually asks, I don't know if any of you are familiar with the questions, it asks to what percentage of do you do it for less than 25% of your patient population, 25 to 50, 50 to 75, and then all the way up. And it's fascinating to see how hospitals rate themselves when you see the rankings. So if you get an opportunity just to see that, it's pretty fascinating. But this is another incentive now. So if it's not the payers, if it's not Joint Commission, it is also hospital rankings. So those institutions that are very oriented around reputational value, it's here as well. And so along with all these standards now that are at a national level, it's also sort of this advent of just technological advances as well in social determinants of health screening. And so one is in your EMR and then the other in online social determinants of health platforms. So let me talk about each one. So social determinants of screening within the EMR. So now you have EMRs, whether it be Epic, I think you all have Epic here, correct, or other platforms. Now there are specific screening questions and wheels and different things that they call them to specifically screen for social determinants of health. And the value is that all providers can actually enter in, what they've screened and report it and monitor it, and everyone can see, different subspecialists can see. So you get a whole view of the patient. I think the other advantage to it is, again, it facilitates population health management because, again, if you have good data and you can look at that data and analyze it, you can see what kind of work needs to be done. The other thing that really fascinates me is the proliferation of all these online social determinants of health platforms. And so, there are these interactive platforms that address social needs. So whereas before, you remember we'd all carry around a big binder that a medical student made for us and then flip through it, realize half the places are closed now. And so this is a major improvement on the way we used to do it. You have these online platforms, they're updated according to geographical location. You could put in your zip code, find out what the resources are. And the nice thing about them, they can use by individual patients. You can work with your patients specifically and go through it with them. And then healthcare entities can get different versions of these platforms where they also come with personnel support. And so the personnel support from the company may mean that they sort of maintain and sustain the relationships with the different community-based organizations. So I think the one you use here used to be called Eartha, but is now called Findhelp.org. And this is just a very simple display. And you can see all the different icons they have at the top for housing, food. And so this was a search I think I just did on food. And you can see you put in your zip code, and then all these resources come up. So you know exactly what's truly active in terms of resources and where to go. So the benefits of these online platforms are many. So one, they could be integrated into electronic medical record. They could be used when social workers actually aren't present. So if you can navigate it with your team and with the patient, you can help them. As I said before, the resources are up to date, allows the providers to monitor these social determinants over time. And then lastly, I think this is really it can be effective where you can do analyses of your patient population, see what the needs are at your hospital. If it's food insecurity, then you can start a major food insecurity initiative. So it has all these benefits. So these are, again, all the different forces, the availability of technology. But then the question is, well, what does the evidence say? And I would say at this point, it's really hard to say. So a lot of the studies that we have in terms of interventions around social determinants of health screening and addressing them as well, is they're small, they're inadequately powered. A lot of them are observational studies or pilot studies. Good work, but still just not the level of rigor where we can say much. And a lot of these studies, there's heterogeneity about which social determinants of health is actually being studied. So it could be food insecurity in one, it could be transportation in another. So it's really hard to put all that data together and come up with what the true direction of some of these outcomes are. And then if you look at a lot of the outcomes that are in some of the studies that exist now, a lot of them just, we referred a lot of people. That's our outcome, success. Congratulations to us. Or, these people actually made it to the food bank. And those types of outcomes are just inadequate because they don't cover the health outcomes. They don't look at the long term. It's just sort of this self-congratulatory process of I got the patient connected. And that is totally inadequate. So off my soapbox. And then most of these studies are in the ambulatory setting, but I think where there's a lot of potential is actually to do them in the inpatient setting as well, where you have patients over a longer period of time. The last thing I would say is there has been some promising data about addressing social determinants of health from the 1115 Medicaid waiver programs, but those programs aren't meant to be rigorous in their evaluation in the way of a research study. So it gives some signal that these interventions work, but again, not done with the rigor where you can say for sure. So that's where we've gotten a lot of our data, and that's the state of the evidence for now. So what I want to switch and talk about now is just what does screening look like and how do we do it and what are the priorities? So when we think of screening typically in healthcare, it's to identify something that is an undiagnosed condition in an individual. They don't have signs or symptoms. Our goal is to identify it through our screening. And then the idea and connection is if we identify something early enough, it leads to early treatment, intervention, and then in turn, better outcomes. Now, with social determinants of health, it's a little different. Now we're screening for social needs that the patient and or family, they're well aware of. I know I'm poor. I know I'm housing insecure. I know I'm food insecure. And then the treatments and solutions lie outside the healthcare system. So the healthcare system is here, and then all the answers in theory lie somewhere else. So how does that work together? So a little different from this concept of screening that we've learned. And it creates all these ethical dilemmas. So, screening first may reinforce different types of biases or stereotypes. So as a Black male, I go in to see my doctor and he starts asking me about food insecurity, violence, housing insecurity. It's like, whoa, that's a lot, because I know what stereotypes may exist out there about me. And then you start asking these questions and it makes me want to withdraw within that healthcare setting, because I feel like these are already stereotypes that I experience in society. And then, patients may just see, hey, these questions are out of the scope. I came here for asthma. Why are we talking about food? Why are we talking about violence? I just want to hit my inhaler refilled. And then there's this concept called patient abrasion. At least that's the term my institution uses, where the repeated asking about social determinants of health is traumatic to patients. So come into the ER, you get asked about it. Go up to the floor, you get asked about it. The new team comes on the next day, you get asked about it again. So again, those repeated requests and for responses all can be traumatic for patients. Other things that could cause harm is that patients may develop new expectations of providers. So if Dr. Chamberlain's asking me about my housing, she clearly has a solution because she wouldn't ask otherwise, right? So maybe Dr. Chamberlain, because she's so phenomenal, she could she could do something about it. But for those of us, most of us out there, we could not. So you have to worry about the new expectations out there, and then screening for factors for which there are no available resources. We know that well. We talked about this yesterday in our meeting, so that is always difficult. And then the potential to overburden community agencies. So if we start sending so many patients to the food bank, and the food bank gets overwhelmed, we may crowd out the people who the food bank is intended to help, those in dire need. And we're sending all these patients, our families, who may have need, but not dire in the way that the food bank is there to do. So there are all these dilemmas out there. And so I think it's important to really have considerations for best practice, both on the screening side as well as dressing side. So on the screening side, you have to think about, are you going to do focus screening, meaning one or two social determinants of health? Or are you going to go for everything? The argument for focus screening is, hey, let's be focused. We know how to screen. We have great questions for this particular social determinants of health, and we have the resources. We know the community agencies to refer to. So that makes sense. The argument for expanded screening is you don't know what you don't know. So we make all these judgments in healthcare thinking this is what families need and these are the areas we should screen for. But sometimes, for example, families may have questions about childcare, and childcare is not in a lot of the social determinants of health screenings that we do. We're asking about food and housing and everything else, and it's really these other areas that people would like to be asked about. So that's the tension between focus versus expanded. Frequency. So back to this concept of patient abrasion. How often are we going to ask people? Are we going to ask them 5 times in the same visit, in the same admission, at each subspecialty visit, then primary care visit, urgent care, well child check? So we have to think about all of that. Then another area that may sound a little nuanced is how you even ask the question. So getting at need versus want. So I may be food insecure, but I figured out how to do that for myself. I don't want your help for that. I want your help for childcare. So just how you ask the question may create some misalignment between you and your families, because they have a way to figure out something already, and you're like, okay, here are all these resources for food, and they figure that out. And so just how we ask the questions, do you need help with this, is very different than do you have this need. So thinking about that. Other issues is who screens in terms of, is it the provider, is it social work, is another member of the team, who has the best rapport to be able to talk to families. Data collection obviously is a big thing. How do we collect that data? Where does it exist? What are all the liability issues in terms of how it exists in the medical records? So all of that has to be thought of too. And then addressing social determinants of health, making sure we collaborate with all our team members, specifically social work, because a lot of times those are the individuals that have to carry all that work. So I've seen so many times where clinicians say, oh, I'm going to introduce this program tomorrow, all this screener, it's 5 pages, and they haven't even talked to their social worker, who will end up having to do the majority of that work. So just making sure we collaborate with all team members, partnering with community organizations for all the reasons I mentioned before, leveraging technology, whether it be these online platforms, screening within the EMR, and then just getting feedback on referrals. If you overwhelm some of these community agencies and you don't know it, you're causing a lot of harm. So figuring out a way that they can tell you, time out, stop, where we have no more for you, or to even reasonably say, 30% of the referrals you sent us last month were inappropriate. These are the people we're targeting, not these individuals. So having, just like with QI, having that audit and feedback loop is so important, even when you're thinking about social determinants of health. And then these are just initial things I think they're important. So coding of data on race ethnicity. So Kim Huang in PHM has done some great work on this. And so that's important in terms of what we think is in the EMR versus how families identify themselves as well. And then moving beyond just traditional demographics. So now thinking about, just impact of intersectionalities. So minority women or different other kinds of groupings, disability, and how they come together because their needs may be different than sort of the traditional identities that we think of. Racism obviously is important. Collaboration across sectors, including payers, now that they're so incentivized to do this work. And then the next thing is just stakeholder engagement and having it early. So I think it's so important to involve our partners in the community, whether they be health workers, community health workers, or community agencies. And just the approach we need to have is have that introspection, humility as we work with them. It's not about us, it's about them. And the goal is to really amplify their voices as opposed to ours, and really taking that broad approach of health in all policies. So all the policies that are being put forward or thought about in your communities, how does health figure into that? And I think, the other side of that I want to talk about is what I call avoiding engagement malpractice, which we all do. We're all guilty of it. I've done it so many times. And I just wanted to go over them briefly. So one is just refusing to listen. So sometimes we have these great ideas about, how we're going to address social determinants of health. We think we give ourselves credit for meeting with community stakeholders. We say, I'm going to create something in the EMR that prompts doctors to do this thing, and that's going to work. And then, the community members may say, well, what really is a concern for us is mental health. And you say, oh, okay, well, that's not what the grant is on. And you may not say that externally, but that is sort of what you convey to those individuals. And so it creates this misalignment where you're saying, I'm here to get your input, but then you're just not listening to them because you're so direct in terms of what you feel the solutions are. And then it may be that you're influenced by the grants that are available and what your own career aspirations are. So that's one. And then deceiving or changing course. I think, again, sometimes based on our incentives, we may start off by telling our community partners one thing, but as things change for ourselves, we shift and we move around, and then we just drag them with us. We don't re-engage them to say, I want to change this project and how it's oriented. What do you think of it? We just move and then we just assume they'll follow us. So that's another area where we practice, again, what I call engagement malpractice. And then just pushback, right? And so if someone says it's mental health and you say, well, based on the studies, it's not. We just have to do this. And then we can sort of put that mental health thing in later somehow. So just not listening to our partners and actually being forceful in our pushback. And then the last one, again, is one we all do, is serve our own purpose. And I think this graphic really displays what we do to our community partners. We see a foundation grant, we see an NIH grant, other federal grant, and we say, we're going to address social determinants of health. We get these folks together, we ask them for letters, sight unseen, and then we expect them to do it. We don't really ask them what they think. We draft a letter for them, and then we disappear. If we get the grant, we'll email them and contact them again, but if we don't, we never hear from them. So I think it's so important to make sure we don't do that and understand all the work that they're putting in is not just people to have as a partner in a tokenist way, but actually have it in a meaningful way. So I think, sorry, go ahead.
I was wondering if then sort of thought about how to maybe revise the way that grants are seems like in a way there are grants out there for these things, and then we go apply for those things and try to apply it. communities.
Mhm.
I don't know if there's any thought about trying to apply grant money to communities and for their own sort of ideas and have us. But we have this expertise, we can bring it to you.
That's a great point. So now you're seeing so many more federal agencies and granting agencies say that they want patient engaged research. So now they're saying as part of your research to have team members actually be people from the community and be all these stakeholders. And so now it may be a community advisory board, or it could be that they're actually thought of as investigators. So what you're talking about is actually happening. So these are all the ways that we don't do things in the correct way. So again, just to summarize, all these new forces, these are the things that you have to think about in screening for social determinants of health. And what I want to talk about is, historically, what it's been is in a lot of individual providers and people doing it. Now, what are the differences now that we're going to more systems-based approaches? So historical nature of social determinants of health screening in our settings is they're typically driven by individual providers, individual clinics. I got an email last week from a cardiologist who created this comprehensive screening program, and it's phenomenal. And then, a lot of times historically it's been centered around the frontline providers and families. So this small unit working together, but overall little standardization and structure, processes and outcomes. Our screening tools are all over the place, even within the same organization, they can be very different. No organizational oversight, poorly resourced, limited alignment with the organizational strategic plan. And then it's really, for the most part, it's purely mission-based, meaning sort of been designated or stereotyped as do-gooder work. So what's happened now is that, with that model or what it's been historically, if you look at these social determinants of health, only a quarter of US hospitals even screen for these 5 needs. And that might be an overestimate because I think sometimes we don't always tell the truth. And so I think this is actually the best case scenario of what it looks like. So now, think about this new landscape. Now you have incentives from payers, from the Joint Commission, hospital rankings. You have the availability of technologies to screen and address social determinants of health, all these online platforms. You have emerging evidence on addressing social determinants of health that could actually improve outcomes. You have engaged faculty and trainees who all want to do this work. And you have the proliferation of DAI officers, vice chairs, in DI who are ready to provide the leadership appropriate to make this work happen. And increasingly, you're seeing health equity really incorporated into organizational strategic plans. So now with all these external forces, people ready to do it, you would ask, what could possibly go wrong? And this is where I go back to what Paul taught me when I was a resident and what makes me so angry and passionate about what I'm seeing with social determinants of health is now you have all these larger system leaders and stakeholders who are now involved, and they may have divergent and competing priorities. And they're all due to the party, right? It was the providers, the clinicians, social workers, care coordinators, family advocates who are really focused on social determinants of health. And then all of a sudden, the executives walk in, these other administratives walk in. So it may be quality and safety, and their involvement is around Joint Commission, around US News and World Report, clinical operations, making sure that this could be integrated in a way that it doesn't slow down flow. And then finance may be motivated by billing and Z codes and all these other ways to take advantage of new value-based modeling. Information technology, just making sure how all this works. And it can be, historically the clinical team that typically did it. And the problem with all of that is all these people new to the party is they have various skill sets, different motivations for being involved in social determinants of health. A lot of them have not historically done this work, and they have experiences that are not consistent with doing this work. You have this tension of who actually owns it. Is it quality? Is it the providers? Is it finance? And you just don't know. And I think it makes it harder to move the agenda forward when you have these new stakeholders and some people saying, no, oh no, I own this piece or I own that piece. And that just creates this potential for a lot of siloed and fragmented efforts and just inefficient use of resources, because I may be creating one program here, quality may be implementing another program here, and we're using different personnel, and those personnel can be all be together and rowing in the same direction. And then you just have these different goals and incentives and drivers for actually doing the work, and that can shape how programs are developed and implemented. So let me talk about a few differences. And before I do this, I'm going to give a big disclaimer. I am exaggerating a little bit the role of everyone, so I don't want to get complaints from finance, quality teams, or whatever. I am exaggerating and stereotyping a little bit more to make a point. So, as you think about putting together a social determinants of health screening program, so from finance's standpoint, their motivation may be to the opportunity to optimize reimbursement under value-based payments. And so their program may focus on screening for social determinants of health for which there's reimbursement. So if they say for housing insecurity, food insecurity, they're just going to say, let's do just those things and call it a day because there's reimbursement for it. And so their lens is very different. And based on what can be reimbursed for, they may not have a lot of attention to the other things, like the actual provision of resources to families. So that's one perspective. Then if you're in quality and safety, your perspective on social determinants of health may be a little different. Your motivation may be that, oh my, I have to meet all these numerous requirements for US News and World Report, Joint Commission. And so I'm going to create this really extensive screening program. But potentially the downside of that is you burden families and clinicians because the clinicians have to screen and the families have to answer all these questions that may not know exactly why you're doing that. And so the worry here is that you may be promoting what I call a checkbox mentality in your approach. And so that may be their unique lens of what they need to do for their incentives. But again, that shapes what social determinants of health screening looks like. And then the clinical team, again, this historical group that typically owned, however you want to term what that means, social determinants of health, they may say, well, we want to address health equity. And so they're going to create these super ambitious programs that promote family voices in all the ways that we'd like them to. But those programs aren't really easily implementable. They're not scalable. And they may not fit all the different domains that you need for Joint Commission or other areas as well. So that's just a different perspective. And so that's what I mean by all these incentives, competing priorities, and again, with all these new partners. The other thing I think about too is just the rapidity of implementation without really engaging key stakeholders. So with all these new individuals and stakeholders and leaders involved, now is the potential for families and clinicians to actually be marginalized in sort of the visioning and decision-making around social determinants of health. And that we have to remember too is the way we screen with social determinants of health, it's deficit focused. So when we're talking to families about all these deficits in their lives, that could be traumatic for all the reasons we've discussed. Now, with large scale screening, now you're asking all your providers to screen primary care, subspecialty care, potentially inpatient as well. They may not be trained adequately in how to screen or to provide resources. And then the other area with large-based screening is that parents may not want to discuss social determinants of health in front of their children. So I do the screen, and then the provider comes in and says, let me talk to you about your food insecurity. Oh, wow, the kid had no idea. And now the kid does, in a very real way that the family did not get to initiate that conversation with them. It's, the provider does. And so that could be traumatic. The other thing too is imagine if someone fills out a developmental screen and they're also filling out a social determinants of health screener, and the child has developmental delays, and they're coupling that in their mind with the social determinants of health screener. So then you feel some guilt if my child has developmental delays and I came out positive on the screener. What does that mean? Because why did the doctor couple those screenings together if they're not meant to be linked? So that linking is going to potentially have harm as well. And then documentation of social determinants of health in the EMR may have implication for custody disputes. So with the 21st Century Cures Act and so much more access to our medical records, if two family members are having a dispute around custody, and you can see everything, you can see all the screens that have been done and what the other person is positive for, then that could have huge implications. So huge legal issues that hospitals are grappling with. So all of that really requires a need to be thoughtful. So just a few recommendations on making large-scale social determinants of health screening healing-centered. I think one is just creating some type of governing body within your institution that includes all these different stakeholders, in addition to all these new administrative leaders who've become invested. And that committee can work on developing guidelines around how frequently to screen and in what settings to screen as well. They can also review all the wonderful, exciting screening platforms, the technologies, and the personnel investments as well, because that's a lot of money and you want to make sure it's efficient. So I think having some kind of organization or governing body that comes together is meaningful so everyone's needs can get met. All the motivations, all the incentives can be discussed in one place. And then just the importance, I'll get to it at the end. And then just the importance of co-creating with patients and families in terms of how they want you to screen, how they want you to actually ask the questions. Remember what I said before about need help versus want help. And then, what to do with families in terms of if they're experiencing social terms of health, how to provide resources, and then just making sure we include families whose identities have been historically excluded in these major decision-making within healthcare. So that's the other area. And then just enhancing cross-sector and community partnerships. So recognizing, there's a huge difference when we talk about, large-scale screening, because now you could really, really impact these community organizations, because if your hospital is seeing, thousands of kids a day and you're screening everywhere and you're sending them off to community organizations, you can really outstrip them of their resources in a very fast way. And again, like I said before, you can crowd out families who are there, those resources are actually meant for. And then understanding the harm in referring families to programs for which they are not eligible. So you send them to the food bank and the food bank screens them and says you're not eligible. So that actually disrupts trust between you and your families, because you sent them someplace and then they may have felt embarrassment even going, and then they don't get the resources there. And I think the other thing, again, getting back to our community partnerships, is now recognizing in large scale, if you're going to do this work, that they're going to be impacted. So developing some type of financial partnerships where there's some kind of exchange. So they're, wrong word is reimbursed, but where you can support them. That's a better word, supporting them in terms of the work that they're doing, and not just assuming you can just dole out all these referrals and they're just going to do it. The next thing I would say is really couple your institutional efforts with advocacy. So you can't do all this work and then not be involved in advocacy. So you have to be out there as well. As one is just promoting the need for reimbursement models that emphasize resource provision, not just screening, but resource provision, and then making efforts to protect the social safety net. So again, large scale screening, you need a safety net out there. And so we all need to be out there as well, arguing for the need for the social safety net and funding for it. And then I think lastly, as important as we don't think about, as well as engaging with the business community to support our efforts, because they may be incentivized in different ways. So working with them is going to be a major win for us. So in conclusion, the healthcare landscape has changed fundamentally just in the last couple of years with what you're seeing from CMS, Joint Commission, US News and World Report. All these new forces are making social determinants of health screening actually an industry standard. Imagine that. For those of you who've been doing this work for years and years, Jochen and I used to argue about this in our offices side by side, how to do all this work. And now it's actually an industry standard. And that's great news. And it brings all this great potential to do great good. But large-scale screening in pediatric settings introduces all these new tensions, all these new stakeholders, all these new people to the parties So you have to integrate that and work together, and then find a way within all of that, within all these new standards, to make sure that initiatives are healing centered. So when I think about social determinants of health and all of what's going on, I always think of my 3 kids. So if you look at the 2 on the left, the older ones, they give you the, nice smile, just smile for the camera. And they're excited about social determinants of health, and maybe they are, and what we can do. And then you have my youngest, Zora, who's giving that skeptical look off to the right. And that tends to be me in terms of where I place myself in the social determinants of health discourse. Is I see the opportunity, but I also see the potential peril. And I think it's just something that we have to keep an eye on and just all be engaged in. So with that, I will conclude and take questions. Thank you so much.
Thank you so much.
Thank you so much for that talk. You articulated so many thoughts in my head that have been swimming around much more better than I can say. So, I guess what I'm struck is a slide you had earlier that sort of questioned the evidence of the effectiveness of large-scale screening. And I'm surprised how quickly both payers, Joint Commission, and US as grabbed onto this as being the thing we should do without the evidence being there yet. And so I guess I'm wondering from your perspective, what could be some other approaches besides large scale screening to get at addressing social determinants? Because I think we've all bought into the evidence of that. Mm-hmm. We're just now questioning whether the screening is the appropriate strategy to get there.
Right, and it's all these ethical issues that come up in terms of potentially doing harm. So some people would argue, instead of large-scale screening, maybe you just ensure that you provide resources. So in your clinical settings, that people can see if they need help there. It could be a kiosk, it could be a form or some booklet where this, all the resources are there, but they're, because of the potential harm and all this large-scale screening, that maybe that at least that's one potential other way to consider it. Yes.
I had another question.
Absolutely, let's go.
So I think at least inpatient, I feel like when you were saying like in the ED will screen, and then with the different inpatient teams, we'll turn over and maybe they'll rescreen. And I was wondering twofold. One, I feel like so much, especially as a resident, so much of the time we focus straight on the medicine, or I guess like the physiologic medicine. And we only find out from social work, like, oh, this family doesn't have access to transportation. They live 3 hours away. And so my first question is there any studies on who is the most effective in the hospital about screening or identifying and connecting needs? Because my initial thought is I can ask about all these questions, but I'm just going to ask social work to help me because I don't know all of the resources. And to some degree as a resident, I feel very like strained for time and mental energy to be able to manage all of those things all at once. And my second question, which kind of goes along, is are there any measures to have like a dedicated inpatient team that would kind of be, like we have adolescent consults and they just stalk all the admissions, see who's a teenager and see what's been said about them. Right. And so like, has anyone tried anything like that where there's like a specific team of a social worker and a hospitalist or something like that who can go around and sort of like triage these things so there's more continuity and maybe more expertise than having the residents like go in and ask these questions that I honestly we're just haven't been super equipped to be able to effectively manage.
Yeah, that's a great question. So there have been a number of studies on who is the right person. I think a lot of times these studies show that people connect with their clinicians. And so because of that relationship, they like getting those questions or having that interaction with them. But then there are other studies that show even the mechanism of how you do it. Is it a person? Is it a website that you go to and fill out the screener? Is that what's most helpful? And so you find, I would say it's hard to find things that are all in the same direction in terms of what people like and how they like to be screened. But I think there's a lot of studies historically when it comes to these sensitive issues that people want to hear from their providers specifically. So that creates more work, but I think it's a requirement that means that we need more training on that. And to your other point about new ways of teams working together, I think those are coming in terms of having different teams, be much more proactive in the inpatient setting. And I think those studies are underway. I don't know of any major results yet, but I think that is something that people are really starting to model, whether it be care coordination, community health workers that are either hospital-based, community-based, spend time in the hospital, do screening. I think there's a lot of research going on there.
Dr. Rapheal,
yes.
Perfect talk, perfect timing. Thank you so much. You're just going to fast forward us. I can feel it. I've been so frustrated by the platforms, the Aunt Berthas of the world. I find two things. Number one, when we first started to see them and we would pull them up and ask it a question about food insecurity, it had the high level stuff. It had the stuff you could find on a web search. It didn't know St. Francis of Assisi in East Palo Alto served a hot dinner every Tuesday and Thursday. Like we had community knowledge that never popped up to the top level. So number one, is there an opportunity or have you seen a way for people who know their community to add things, to enrich them, for it to be a little more bidirectional? And number two, same frame, families should be able to provide Yelp reviews for those services, because a lot of families will come back and say, I don't want to go to that one. They're not nice. They don't speak Spanish, whatever. And so I'm wondering if, I guess overall, it's where's the bidirectional opportunity with these platforms? And because I think it's important that it be more accurate, more hyperlocal, more family voice. And I think it's an opportunity for this region. We excel in technology and just wondering if we can't think about a Stanford add to those platforms.
Those are great questions. Those are the same frustrations I have. And so, again, sometimes institutions just, obviously it's out there on the web, you can just use it, but there are versions that institutions can purchase that in theory come with personnel. So I've asked the question to the findhelp.org personnel. So they say, what I can do is I can go out into the community and nurture the relationships and and I think we specifically asked that question, can you get input, like you said, about that hot dinner on Thursday night? And they say, yes, but it's not clear that they can really do it in a meaningful way because I think the algorithms are still the algorithms. And so what exists online is always going to be there. So I think from my own inquiry with some of these online platforms, they have the personnel who can do it if you pay for a certain amount, but whether they can do it in the way that more organic sense in real time, I don't know.
Hey, it's such a wonderful talk, so thoughtful, and thank you for putting this all together. It's so timely for us because through our California-wide network, CPQCC, we're actually gearing up to do a social determinants of health intervention with about like 30 or so NICUs. So we're kind of getting ready for that. I just wanted to invite any of you who are interested in this work to kind of maybe join us on this journey and learn, because there's going to be a lot of learning, particularly, like some of these things might seem just sort of barely feasible to do within a children's hospital, but we have a lot of our NICUs are like small community hospitals that share a social worker across multiple units. Like, and they, so it's sort of kind of maybe the same question as our residents sort of had. It's like, who in the end takes something like this on in a regular hospital? Because this is a major job. This is not something you can just kind of sort of do on the side. So yeah.
Yeah, no, I think it's in some places it's going to be, a health equity center. Other places it may be quality, and so they sit, and we were having this debate yesterday when we were talking is where does it sit and how does it intersect with all these other efforts that seem somewhat overlapping as well? So it's, do you have the personnel? Do you have the resources? And are you actually sort of stepping on each other in terms of, it's almost like a bottleneck of health equity and social determinants of health and DEI, and how do we make sure that we take all the resources that we've gotten now, all the personnel as well, so it's done in a meaningful way, because there's so much work to do, as you said, but I don't think we've all figured out how to lead it from an organizational perspective.
I think one of the things we're excited about here is the potential of utilizing community health workers and maximizing some of the new policy things that are happening at a state level, and how we can think about what could be done to really expand our reach in addressing social determinants of health. So that's one area we're thinking about here locally. So I think it will be really interesting to see what we can do.
Gene, great talk.
Thank you.
Thank you for your leadership. As I sat here and listened to you, it struck me that social determinants of health is a subspecialty in healthcare, a crossover between medicine and public health. And as such, it concerns me that when we put committees together that make up different people, different views, different experiences, it doesn't lead us towards refining the subspecialty, so to speak, over time, so that we gain knowledge, particularly not just regional knowledge, but national knowledge. And so I wonder whether we're exploring a field that is no longer, like a old pediatrician walking in and saying, I can take care of diabetes. I don't need Darrell Wilson to do that. And at the end of the day, we can kind of do it, but not do it real well. And we don't advance the field. So, as we think about this, it strikes me that it is an opportunity to reframe the agenda, to look at it as a multifaceted process that's ongoing in every community differently, ongoing in every hospital. So you almost need a subspecialist to think about all those facets and how we move the project forward. I don't know, what you're thinking in that?
I mean, I think that's where we're evolving to, because there are so many different types of needs and requirements that it's not I think what I was trying to express or articulate is what we've done before historically, where it was just sort of, oh, I'm going to wake up today, I think I'm going to do this in my clinic. That's not adequate anymore. And and doing it that way was probably, probably not the way it needs to be done in an ideal world. Because now, as you said, it's sort of essentially become, you need a lot of expertise to do it the right way. And I think conversations that I've had with you and Paul in the past, as well, as you don't want to subsidize the work of what other sectors should be doing. And so finding that spot of what healthcare can contribute is going to take a lot of work. And I don't think we figured that out yet, because I think these standards are coming so quickly and people are saying, yeah, I can't wait to do it, but are we doing it in the right way? I don't know yet. And so I think we're still on that journey. And I think we're going to learn a lot of lessons in the next few years as we try to meet all these different standards and priorities that are there. So that's my thought, is that we're not there yet, but it can't be the way we've done it historically. It's too hard and we're harming patients in the way we do it.
Thanks, Gene. It's nice to see you've made some progress since you were a junior resident.
A little bit, yeah. Thanks to you.
Hardly, but spectacular to see you, and thank you for this presentation and your leadership nationally. The struggle for justice and the struggle for outcomes research are not the same thing. There are powerful disincentives built in to the current discourse against doing good outcomes research. It's not necessary for many of those engaged in this work. How do you navigate this? And how do you anticipate outcomes research that basically shows a little change in health? And yet we know that it's an important contributor to the struggle for justice, things that we shouldn't back away from, but yet may not be directly supported by good p-values with outcomes research?
That's a phenomenal question. And I think, and in our conversation already, we're moving so quickly and the research is not showing, it doesn't always consistently show the value that we would expect to see. I think part of that might be, again, a lot of these studies that we've done have been underfunded, not necessarily designed in the best way. So I think there's still just a rigor question to some of the research we've done, which is maybe part of the reason why we don't see much impact. And so I think that has to be resolved. We need to, obviously funders and all that have to do it, give adequate resources to be able to do the work in the right way. I think there's so much that have come from these 1115 waiver programs, but again, they're not evaluated in a rigorous way. So they just give, as I was saying before, these just little signals that it might help, but it's a little bit, same way, historically we've seen with medical home, even the research on medical home has shown just a bit of improvement. It doesn't show a great deal. So I think, trying to look at what we're seeing with outcomes research, which shows just a little bit, and then that argument for justice, it's hard to figure out where the right way to go is, because you also don't want to say, I'm just going to focus on just with this justice lens and then put resources into things that actually don't work. So I think what we need to do is really find a way to do the work better. And hopefully those things start to line up between the outcomes research and the justice argument. But if they don't, then we have to think about doing the work a little bit differently, because I worry about us putting resources and funding and everything in, and really it doesn't do much for our patients, it doesn't do much for our families. And we sort of congratulate ourselves on the justice side, but ultimately then it doesn't lead to justice either, ironically, right? Because if you're not investing in the right ways and you're harming patients, then that's not really a justice intervention. And so I think a lot more work on just the design, the studies, the funding of them, and doing them the right way, and then just being willing and open to see if it works. And if it doesn't work, then we have to think about different approaches. I think ultimately that's where we have to land on doing this, because at the end of the day, that's not going to be justice. Ooh, that was exhausting. Thank you, Paul. I'm going to be thinking all the way back to Houston tonight.
Thank you so much for really elevating our thinking in this area. This was such a great grand rounds.
Thank you so much.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.